for sensation to the fingertips. You can bend a paper clip, which we don't have here, but you could bend a paper clip, making the points of the two ends somewhere between 5 and 8 millimeters. And then you gently take the paper clip and touch it to the finger, just blanching, so not more pressure than just blanching the skin, and see if the patient can delineate 1 or 2 points. Normal would be somewhere less than 8 millimeters. Excuse me. Greater than 8 millimeters would indicate an abnormality. That would be a static 2-point discrimination test. A dynamic test would be while taking those 2 points or single point, you gently move them along the digit to see if they can delineate the 2 points as well. The reflexes can be tested. Biceps, brachioradialis, and triceps. The ulnar nerve runs from the arm just posterior to the intramuscular septum, posterior around the medial epicondyle in the area of the cubital tunnel. It then splits between the flexor carpi ulnaris before going down towards the hand. The ulnar nerve can be pinched anywhere from 10 centimeters proximal to the medial epicondyle all the way to 6 to 7 centimeters distal. Patients with cubital tunnel syndrome will have symptoms with elbow flexion or a tenels or tapping over the nerve. Some patients' nerves will snap over the epicondyle. Here the nerve runs up just to the epicondyle but doesn't go over. Cubital tunnel. Patients with cubital tunnel or ulnar nerve symptoms will complain of numbness on the dorsal ulnar part of the forearm and hand if the compression is at the elbow. If the compression of the nerve is at the wrist, the dorsal branch would have taken off already. There should be normal sensation here as compared to here, but there might be numbness on the palmar side. Patients with ulnar nerve symptoms of a severe nature will have involvement of the intrinsic muscles of their hands, and they will be unable to cross their fingers. We test thumb index pinch strength, the first dorsal interosseous or adductor muscles pull, and this is a normal innervation. Patients with abnormal innervation will flex their thumb to try to keep the paper or object between the thumb and the index finger. That is called a positive Froment's sign. Patients with intrinsic involvement will have a drifting of their little finger, and this is an observation. They cannot bring their little finger adducted towards the ring finger. That's called a positive Wartenberg sign. Patients with carpal tunnel will have involvement often in their thenar muscles. The flexor pollicis brevis will be weak. Push as hard as you can. You test this by having the patient push their thumb and their little finger together and palpate. If there's weakness there, see as I can demonstrate, he's a little bit soft. Relax. If you look on my hand, very firm. Patients might have atrophy in that region as well. Patients with carpometacarpal arthritis of the thumb complain of pain and swelling in this region, and a grind test, grinding the thumb metacarpal into the trapezium bone, will cause discomfort. Patients with ligament injuries of their fingers, such as a gamekeeper's thumb, where the ulnar collateral ligament has been disrupted, will have laxity. By supporting the metacarpal with my right hand, I'm radially and ulnarly deviating the thumb with my left hand, checking the status or the competency of the collateral ligaments. Each of the lesser 4 digits has 2 flexor tendons, a flexor digitorum superficialis, which flexes the finger at the PIP joint. So bend it here, no, or here. The flexor digitorum profundus will flex the DIP joint as well. Flex this down, Flexor digitorum superficialis each has an independent muscle belly. By isolating this finger, we could identify then if this flexor digitorum superficialis is intact. By keeping the other digits in extension, I'm isolating the FDS by not allowing the flexor digitorum profundus to flex the finger. Extend. Next. Go ahead. Extend. And go ahead. Open up. All of his flexor digitorum superficialis tendons are intact. We isolate the flexor digitorum profundus by simply asking him to flex the tip of his finger. There's one muscle belly for the flexor digitorum profundus. By isolating these digits, we ask him to flex this finger. He cannot fire his flexor digitorum profundus. Radial nerve palsy, all the radial nerve muscles, which are the extensors, would not be functioning. Patients have a wrist drop. They cannot bring their wrist up. They cannot bring their thumb up or over here. To test for a radial nerve palsy, you want to see that they could bring their wrist up and bring their thumb up and over. To isolate the long extensors, which are innervated by the radial nerve, we ask the patient to flex their fingers and extend the MP joint. That isolates the radial nerve innervated extensor digitorum communis tendons. Patients with a radial nerve palsy, drop your fingers, can bring their fingers up like, partway up like this, by firing the intrinsic muscles of their hand, which are innervated by the median and ulnar nerve. So don't be fooled by a patient that's got a wrist drop but can bring their fingers out like this, because that might be extending with the use of the innervated median and ulnar muscles and not by the radial nerve. To isolate the radial nerve again, we flex the finger and extend the MP joint. Again, we also watch the patient extend the wrist, and with the palm flat on the surface, ask them to bring their thumb up over the plane of the over the plane of the hand and towards the index finger. Patients with ulnar nerve palsy will have clawing of the little and ring finger often. Clawing is a hyperextension at the MP joint and a flexion at the IP joint, such like this. Hyperextension at the MP joints and flexion at the IP joints. In distinction, a boutonniere deformity is flexion or neutral MP joint, flexion at the PIP joint, I'll do this finger, and extension at the DIP. So flexion, flexion, extension. A swan neck deformity is hyperextension at the PIP joint and flexion at the DIP joint, and that's difficult to ascertain on this subject. When examining patients with suspected finger fractures, we look for the nail plane. If a finger is twisted out of plane, that would be a rotational deformity and would indicate possibly a fracture or dislocation along that axis. Additionally, we'll look for flexion deformity for metacarpal fractures. If you can see all of the metacarpal heads, it's likely that there's no fracture along that bone. If the metacarpal head is missing, somewhat like this, you might suspect a fracture in this finger and a flexion deformity of the metacarpal